Hello, my name is Rachel Putman. I'm a physician here at Brigham and Women's Hospital, and I'm going to be talking to you today about granulomatous lung disease. So first, disclosures, I have nothing to disclose. So granulomatous lung disease has a large differential diagnosis, and you can see that there are infectious and non-infectious causes of granulomatous lung disease. The non-infectious causes include sarcoidosis, hypersensitivity, and then we get into some more rare things, including chronic beryllium disease, which we don't see very much anymore as beryllium is not a common exposure, hot tub lung, vasculitis, aspiration pneumonia, talc exposures, rheumatoid nodules, and bronchocentric granulomatosis. We're going to spend the majority of our time in that category today talking about sarcoid and hypersensitivity, since they're the most common of that list. On the infectious side, mycobacterial disease can cause granulomatous disease in the lung. Endemic fungi, pneumocystis, aspergillus, and certain parasites can as well. And we're going to touch predominantly on the mycobacteria and endemic fungi today, as they're sort of the more common causes in pulmonary as well. So this is just going to be a brief overview looking at tuberculosis and non-tuberculosis mycobacterial disease. I know there's a separate talk that you can review as part of the course for tuberculosis for the non-infectious disease doctor. So this is going to be very brief. But when we're looking at tuberculosis and infection, lungs are the major site of infection for this. And the pulmonary complications can be quite a few. And they include hemoptysis, pneumothorax, bronchiectasis, or scarring and distortion of the airways. There can be extensive pulmonary destruction from tuberculosis invading. And then farther down the line, malignancy and chronic pulmonary aspergillosis, which is a chronic fungal infection of the lung, can develop. Radiographically, when we're talking about tuberculosis infections, patients often present with hilar or sort of around the central airways and mediastinum lymphadenopathy. That's in about 2/3 of cases. About 1/3 of cases will have pleural effusions, and then about 25 to 30% of people will have actual pulmonary infiltrates. Non-tuberculous mycobacterial disease is caused by a mycobacterium that is not tuberculosis. And the types that cause infection vary based on the geography. Here in the United States, the predominant causes of pulmonary disease are the Mycobacterium avium complex, or MAC, Mycobacterium abscessus, and Mycobacterium kansasii. Then the symptoms vary in patients based on their underlying lung disease. Most commonly, people will present with cough, fatigue, malaise, weakness, dyspnea or shortness of breath, chest pain, and again, they can have hemoptysis, as these types of infections will often cause cavities, and those can erode into blood vessels and lead to coughing up blood. Now, in people who have underlying lung disease, the underlying lung disease affects whether they can, the type of presentation with these non-tuberculous mycobacteria. So in patients who are prior smokers and have a history of chronic obstructive pulmonary disease, the ones that are more likely to get non-tuberculous mycobacterial infections are white and middle-aged or older men. People who have bronchiectasis underlying, again, that's that sort of distortion and enlarging of the airways, happens in older adults, and there's no difference in sex or smoking in that group. For people who get non-tuberculosis mycobacterial disease without underlying lung disease, that's predominantly women, and they're usually older, over 50, and usually are non-smokers. So moving on to endemic fungi, which can also cause granulomatous disease in the lung. This is going to be a sort of a very brief just overview of the common types that we have here in the United States. And the reason that this is brought up in this section is that they often present these patients when they have these endemic fungal infections with mediastinal and hilar lymphadenopathy and pneumonia, which can make it difficult to differentiate from some of the non-infectious causes upcoming. When you're thinking about endemic fungi, it's really all about the geography and what patients have been exposed to in different locations. So here, we're going to talk about 4 different types. So first is histoplasma, and classically that is thought to be more commonly located in the Midwestern states, and it's usually in the Ohio and Mississippi River valleys is where it's discussed. Blastomycosis can cause more of a systemic pyogranulomatous infection, and it's primarily located in the South Central and Upper Midwestern United States. Now, I will say if you actually look at a map, the overlap of the geography of those 2 places is pretty substantial. However, for boards for the purpose of the boards, they're usually very specific about sort of locations where there's not overlapping. So blastomycosis would be more sort of upper Midwestern, and histo is often sort of more in the Ohio River Valley. It's sort of the classic questions about those. Cryptococcus has a worldwide distribution in terms of endemic fungi, but it is most common in immune-compromised hosts, so it's much less common to see in those with intact immune systems. And then coccidioides has a much more distinct geographic distribution. It's most common in the southwestern United States, but particularly in Arizona and the San Joaquin Valley in California. So those are sort of the important clues when you're looking, you'll hear thinking about someone's travel history and trying to put together a presentation with their radiology and their symptoms. And this is why it's important to always think about endemic fungi and other infections when you're thinking about sarcoidosis or sometimes even hypersensitivity pneumonitis, is that on chest x-ray and chest imaging, they can look very similar. So what you can see here on the left of the screen is a patient that actually has a histoplasma infection. And you can see that there's enlarging of the lymph nodes here in the mediastinum and the hilum here, and some increase in some interstitial markings here. Pretty clear lung fields otherwise. And then we move over here to the right of the screen, and this is a patient with sarcoidosis. And you can see again, there is enlargement in the hilum bilaterally, and maybe a little bit of increase in interstitial prominence, but very, very similar imaging between the two, but very different disease processes that we would treat differently. So it's always important to make sure we're thinking about underlying infection when we're thinking about other granulomatous disorders in the lung. So now we're going to move on to more of the sort of non-infectious causes of granulomatous disease in the lung. So one of the first is hypersensitivity pneumonitis. And this is a disease that is caused by an inflammation in the lungs. So when you inhale certain triggers, you get an immune reaction in your lungs. A lot of people will act as though it's like an allergic reaction. It's actually not quite an allergy, but you get inflammation and an immune response. And most commonly, the triggers are chemicals, molds, dust, various fungi, and bacteria can cause these reactions. When you're thinking about what does this look like radiographically, the imaging will classically have upper lobe predominant changes, as we remember back that those are the areas of the lung that sort of get the most ventilation. So things you inhale will commonly affect the upper lung zones more. So you'll get upper lung zone predominant ground glass opacities with central lobular nodules. And central lobular just means sort of following the airways and the blood vessels as they run through. So it won't be as much around the periphery of the lungs, they'll be a little bit more in the center. That happens in the acute setting of hypersensitivity pneumonitis. As more chronic changes happen, so if the exposure is ongoing and not removed from the patient, the inflammation will eventually turn to scar. And in those same areas where you previously had ground glass and these nodules, it can turn into fibrosis and traction bronchiectasis, or areas where there's scarring that are pulling the airways apart more than they should be. And that depends on the duration of the disease and usually the duration of the exposure for the patient. When we biopsy these patients, and this is one thing where it is different from sarcoidosis, classically, you'll see what are called loosely formed granulomas. So there'll be granulomas, but they're less organized than that in sarcoidosis, which I have some examples of coming up in the talk. And these granulomas are also centered around the airways, because as you think about it, as we're inhaling things that are causing this inflammation in our lungs, the inflammation will happen right around where the particles are deposited, which is right near the airway. When we think about hypersensitivity pneumonitis, there are categories of this disease. And there have been multiple different schemes that have been proposed over time, but the one that is most commonly used is one of the first that was proposed, and that is based on just the time frame in which someone has been exposed. And so that is divided into acute, subacute, and chronic hypersensitivity pneumonitis. So acute hypersensitivity pneumonitis is most commonly confused with infection, and it happens pretty quickly. It's often the symptoms will start about 4 to 6 hours after the exposure, and will improve with removal of the exposure over the next 24 to 48 hours. People will usually present with fever, cough, and they can have infiltrates in their chest x-ray that can look like an atypical infection. One of the classic board questions about this is hot tub lung, someone who goes into a hot tub, and this is usually caused by exposure to non-tuberculous mycobacteria in the water that people inhale. And instead of becoming infected with it, they have this immune response. Often patients will be treated with a few courses of antibiotics before it is realized that it is related to an exposure, because usually when they remove themselves from that environment, the symptoms will go away. And often we think maybe the antibiotics were the cause of what helped them. So that's the acute setting. Subacute is a more gradual development of symptoms. So you don't have this immediate exposure and this substantial symptoms that follow it. You get a gradual development of symptoms from a more prolonged exposure to one of the things that you're inhaling. And we'll go through the imaging, but as time passes with this, you can sort of go along the spectrum from the acute sort of more inflammatory changes to starting to get some fibrotic changes. And then in chronic hypersensitivity pneumonitis, the onset is much more insidious. It's much more similar to other interstitial lung diseases where there's a gradual sort of onset of dyspnea over time that is progressive. Often these patients that present with chronic hypersensitivity, they lack the history of these acute episodes. So they can't tell you that, you know, they went into a hot tub and had this fever and cough that happened right away after, or that they were, you know, working with someone and got exposed to this kind of dust, or this, they had a leak in their home and had mold and all of a sudden became very sick. They have this more gradual development of symptoms that progress over time. Here, the imaging is characterized by upper lobe predominant ground glass again, but also with the likely addition of fibrosis, and the fibrosis will depend on the time course. And again, that's the sort of scarring you'll see in the upper lung zones. The classic examples of these, particularly for the boards, are bird fancier's disease. So the antigens in bird feathers can cause, with sort of continued exposure, can cause ongoing chronic hypersensitivity in patients. And then farmer's lung most often comes from a mold inside of hay that farmers are exposed to, but there's all different antigens in wheat, hay, all kinds of grains that people are exposed to that can cause sort of these chronic hypersensitivity over time. And all of these, the most important thing in terms of the cornerstone of treatment is trying to identify the exposure and then removing the patient from the exposure. When we look at the imaging, it does vary across the 3 different phases of hypersensitivity. So all the way here on the left is an example of a CAT scan of someone with acute hypersensitivity. And just to orient everyone to these images, these are axial cuts of the chest. This is the right side of the patient. This is the left side of the patient. And here we are sort of a couple of cuts below the carina, but predominantly still in the right upper lobe and the left upper lobe on all of the images. And what you can see here are these fine sort of micronodules and diffuse ground glass or haziness across the background. And it's in most places across this CAT scan here. A little bit less predominant as we head to sort of the bottom parts of the lung, but very prominent everywhere. To move into the subacute phase of chronic hypersensitivity, you'll see that there's again ground glass. Over here, there's areas of air trapping where you can see that the airways have been involved and there's airway inflammation, and that means that not all the air has been able to leave the lung because of the inflammation that surrounds the airways over time. But then we also see here, we start to see scar formation, and this means that over time, all this inflammation has been ongoing and we're starting to see more chronic changes. As we move here to the chronic picture of hypersensitivity, again, there's background ground glass or haziness where we can see the lung markings, but they're not as clear as they should be, and this should be sort of a darker color gray. But we can also see throughout the CAT scan along here, all in these areas are areas of fibrosis, areas of traction bronchiectasis, where you see these airways that are pulled apart, and you can see them open all the way to the pleural area, which is not normal. Airways should be collapsed down at that point. So this shows that this person has had likely an ongoing exposure and has much more advanced remodeling of their lungs. Now to talk about sarcoidosis. So we're going to spend a little bit more time on sarcoidosis. So this is a multi-system granulomatous disorder that usually involves the lungs. So it's primarily cared for by pulmonologists because almost 100% of cases will have pulmonary involvement. It can also involve the skin in about 16% of cases. Lymph nodes are involved in about 15%. It's probably greater than that, but it depends on sort of the stage in which people present. You can get uveitis and the eye involvement in about 12% of cases, and cardiac involvement is much more difficult to track. Autopsy studies report a prevalence of 20 to 60% of cases, but most registries note it occurs in about 5%. You can also get more rarely liver involvement, kidney involvement, and it's often also associated with an inflammatory arthritis that is not characterized by granulomatous deposition, but just inflammation. So when we're thinking about the cause of sarcoidosis, we know that it's likely a combination of genetics and environmental exposures, and whether that's to an infectious agent, a bacterial agent, an inorganic dust, it's taken into, person inhales it, and we get T cell activation and granuloma formation. However, from granuloma formation, we also know that some people will have spontaneous resolution of their disease, while others will progress to more fibrotic changes. And as yet, it's difficult completely to differentiate who's going to have which outcomes. When we think about the epidemiology of sarcoidosis, the prevalence in the United States is about 10 to 20 per 100,000 people. Here, it's more common in Black Americans. They have about a 3-fold greater risk, with an incidence ratio that's been reported between 2 to 1 and 7 to 1 compared to white Americans. And the prevalence is about 3 to 5 times higher than it is for white Americans. In the US, it's more common in women, so about 1.5 times more common for women than it is men. When thinking about Black Americans, the prevalence rates peak in their 30s, while for white Americans, there's a flat incidence rate throughout adulthood. So when we think about environmental risk factors associated with sarcoidosis, we know there's not one single common cause, but there has been evidence that fungal exposure may be associated. So there's higher levels of a fungal cell biomass marker in the homes of newly diagnosed cases of sarcoid, when people go in and vacuum their homes and sort of try and do air sampling. We know that some people have increased mycobacterial antigen markers in both the serum and tissue when they have patients with sarcoid. And then high levels of silicate dust exposure can also lead to sarcoidosis. And this is most prominently seen in firefighters and emergency workers post 9/11 who are exposed to very high amounts of silicate dust. For diagnosis of sarcoid, you need a compatible clinical and radiologic manifestations to put together. And you need to exclude other diseases that present similarly. So it's that sort of whole list that we talked about at the beginning. And if you think back to that chest x-ray where the endemic fungi look very similar to sarcoid. So anytime we're biopsying patients, we're really making sure there's not infection in those areas. And also concerned about lymphoma or primary lung cancer that could present with sort of similar lymphadenopathy in the chest. The gold standard is histologic, so under the microscope, detection of non-caseating or non-necrotizing granulomas. You'll often read about people and hear people talking about ACE levels, but this should not be used for diagnosis or managing treatment in patients. It's elevated in about 75% of patients with sarcoidosis, but the elevation depends on their underlying genotype. It's non-specific, and it can also be elevated in patients without sarcoidosis. When we're thinking about biopsying, most often the site of biopsy is the lung, and usually it's done transbronchially versus endobronchial ultrasound with biopsy. The diagnostic yield of these two procedures is different, so now the endobronchial ultrasound is available. It is the preferred method for biopsy. That allows you to ultrasound the lymph nodes that are adjacent to the airways and directly sample those. And then you would do in addition transbronchial biopsies to get lung tissue to increase the yield. And here you can see this granuloma, so this cluster of giant cells that's forming that's inflamed, and there's no evidence of necrosis, meaning there's no cell death in the middle of this granuloma. So this would be sort of a classic finding in sarcoidosis. Sarcoid is staged based on imaging, so based on chest x-ray findings. And you'll hear people talk frequently about the stage of sarcoidosis. So stage 1 is where there's just lymphadenopathy present. So you can see here sort of very full hyla, but the lung fields themselves look very clear. Stage 2 is lymphadenopathy and infiltrates bilaterally. So you can see these sort of interstitial prominence on both sides. Stage 3, the lymphadenopathy has regressed, and now you're left with just infiltrates. And stage 4 is fibrotic disease. When you're looking at these on chest CT, these are again 2 axial cuts. Here we are above the carina, here's the trachea. And you can see here in the gray, sort of around the trachea, there are these lymph nodes that are enlarged. And here we're right below the carina. So this right here would be a big subcarinal lymph node. This here is a lymph node, and out here as well, lymph nodes in the hilum as well that are abnormally enlarged. And that's characteristic of sarcoid. And then on CAT scan, looking at the infiltrates in sarcoidosis, you get these peribronchovascular, which is just the fancy way of saying they run along the airways and the blood vessels. Nodules that people talk about looking like galaxies or stars because there's sort of a nodule in the center and they branch out this way. And this is just a nice picture demonstrating that here. So this would be pretty classic sarcoidosis. The prognosis overall is good. So there's not been tons of case series of that are large with many patients, but in the University of Cincinnati, in over 450 patients with a median age of 50, at 10 years, at 5 years, the mortality was 4% and 9% at 5 and 10 years respectively. Obviously, people who were older were more likely to have died, and it also would make sense that people who have more scarring and fibrotic changes in their lung also had increased risk of death. And then patients that develop pulmonary hypertension, either from sarcoid directly involving their heart or just from severe hypoxemia from lung disease, were also at increased risk of death over time. A separate syndrome that is associated with sarcoid that doesn't require biopsy for diagnosis is Lofgren's. And so it's present in less than 5 to 10% of patients with sarcoidosis, but it is the combination of erythema nodosum, hyalurlymphadenopathy, and migratory polyarthralgias and fever that's more common in women. Men present, and they usually do not have the erythema nodosum, and instead of the migratory polyarthralgias, they'll present with a bilateral ankle arthritis. If you have this constellation of symptoms together, the specificity for a diagnosis of sarcoid is about 95%. And again, so because of that, these are one of the subsets of patients that we would not biopsy, similar to patients that just have stage 1 sarcoid, just the involvement of the lymph nodes that is symmetric without symptoms. Another group of patients we would hold off on biopsying. Lofgren's is associated with a good prognosis, and over 75% of cases will spontaneously resolve. So usually the treatment here is just for the migratory polyarthralgias or the ankle arthritis with non-steroidal anti-inflammatory agents. So when we think about who we treat, it's predominantly based on symptoms or evidence of disease progression. We have limited evidence that treating people actually modifies their disease. And we worry about declining lung function, but there's no consensus definition. So most of us would treat for declining in either FEV1 or FVC, even the diffusion capacity, but there's no consensus definition for what declining lung function actually means. And when we think about treating people, you can look at the stages and what evidence there is for treatments. And again, at the top here, you can see that stage 1, no symptoms, just lymphadenopathy. You would not offer any systemic therapy. Stage 2 through 4, it depends on how symptomatic they are, what their lung function is, but the initial treatment is usually steroids. And then we move to steroid-sparing agents, which the most common here is methotrexate, and what there's the most data for. And then refractory sarcoidosis can be treated with infliximab therapy, but usually that's after we've moved from steroids to methotrexate or one of the other agents through infliximab. So now we're going to do a couple board review questions. The first question, we have a 24-year-old woman who's evaluated at a clinic visit. About 6 weeks ago, she fell and had a chest x-ray done for evaluation of pleuritic chest pain. The chest pain's resolved, and she denies any shortness of breath, cough, fever, chills, night sweats, weight loss. Her vital signs and physical exam are within normal limits. And here's an example of what her chest x-ray would look like. And then which of the following would be the most appropriate management? A is endobronchial ultrasound and biopsy. B, high resolution CT scan of the chest. C, prednisone, or D, observation. So in this case, we would recommend observation. So as we go back to if you think back to that CT scan, what you have is classic stage 1 sarcoid. So there's symmetric bilateral hilar lymphadenopathy. She's asymptomatic, and so we would not recommend treating her. Endobronchial ultrasound and biopsy would provide you with the highest yield for diagnosis, but it is unlikely that she would need to move to that. So in looking at prior studies, patients in a series of 100 patients looking at symmetric lymphadenopathy in patients that were asymptomatic, and they were all biopsied and none had lymphoma. So you would likely be able to observe her over time. A high resolution CT scan of the chest might show you some small pulmonary infiltrates, But again, if she's asymptomatic, we would not treat her at that time, and you would just be exposing her to radiation. Prednisone again would be the primary therapy that you would try if you were going to treat her, but again, it's not warranted in this case. In addition to observing her, you would want to screen for extrapulmonary sarcoidosis and the organ systems we previously talked about. So you would want to get labs, look at her kidney function, her liver function, her calcium and vitamin D levels. You would want to get an EKG to make sure there was normal electrical conduction in her heart. And then all these patients should have an eye exam yearly to look for uveitis because it's often asymptomatic when it begins, and patients can lose vision if it's not treated appropriately. So question 2, we have a 22-year-old man with the acute onset of fever, chills, and dyspnea, and he also has a cough. So he's a college student who spends his summers working on a farm harvesting wheat. He doesn't wear any mask or respiratory protective equipment. His symptoms start at the beginning of the work week, and then they begin to get worse and worse. Then he misses a few days of work, and then he'll go back, and the cycle begins again. When you see him, he has a low-grade temperature of 100.1. His blood pressure is normal. His heart rate's 98. He's breathing a little fast at 22, and his oxygen saturation is 94% on room air. On pulmonary exam, he has diffuse crackles, and his chest x-ray has diffuse upper lobe micronodular opacities. So which of the following is the most appropriate treatment? A, counsel the patient not to return to work. B, inhaled glucocorticoids. C, pirfenidone. Or D, sirolimus. So in this case, we would counsel the patient not to return to work. So what he has here is acute hypersensitivity pneumonitis. So he's exposed to the wheat that he's cutting on the farm, and shortly after the exposure, as we talked about, within 4 to 6 hours, he begins to develop symptoms. With repeat and recurrent exposure, those symptoms progress over time, and to the point that he's not able to work, he then removes himself from the exposure, and over the next 24 to 48 hours, his symptoms resolve. In patients with acute hypersensitivity pneumonitis, removing them from the exposure is the primary treatment, and it's been shown that in the next day or two, lung function will resume back to normal. Patients that are removed from the exposure and have persistent lung function decrements, you can discuss whether treatment would be helpful for them. When thinking about inhaled glucocorticoids, there's no role for inhaled glucocorticoids in this disease. They've never been studied. While we would primarily use prednisone, an oral glucocorticoid, for treatment, you would not be using inhaled glucocorticoids. And as above, we wouldn't use prednisone in this case anyway. Pirfenidone is a fairly new antifibrotic agent, which is used to treat idiopathic pulmonary fibrosis, which this patient does not have. Idiopathic pulmonary fibrosis is most common in middle-aged to older adults and is characterized by sort of a classic imaging pattern that involves subpleural reticulation, traction bronchiectasis, and honeycombing. So evidence of advanced fibrotic changes on imaging, which this patient did not have. Also, he's in his 20s, so not sort of the right phenotype for idiopathic pulmonary fibrosis. And then sirolimus is used to treat LAM, or lymphangioliomyomatosis, which is caused by smooth muscle invasion into the lungs, and you get cystic changes in the lungs. Now, this can be caused either by associated with tubular sclerosis or sporadic. It's most common in women, and although sirolimus can help reduce the rate of lung function loss, that's for patients with LAM, which is not what this patient has. These are the references for the talk. Thank you very much.